So good morning, everybody. Unfortunately, I am sitting in my living room in Los Angeles and not on an airplane coming to spend the week with you in Korea. However, I certainly hope everybody is well and look forward to seeing you as soon as possible. So my first talk today is going to be on PSMA imaging. This is, of course, a very hot topic in the field of urology, and I'd like to provide what hopefully is a state-of-the-art update on where things stand right now. So first, my disclosures. In terms of relevance to this, I'm on the advisory board for Lantheus, which makes one of the PSMA products, as well as a therapeutic company called Point Biopharma. So as we know, prostate cancer is a continuum of disease, and there are a number of different areas in which imaging has historically not been sufficient to help guide us in terms of disease management. And I'll focus today in terms of PSMA on clinically localized disease, particularly high-risk disease, that is staging these patients. And also, of course, very common to all of us in our experience is the rising PSA or biochemical recurrence and how to stage patients to select management. So briefly, PSMA is a cell surface protein that's present or expressed in a majority of prostate cancers and is not expressed on most normal tissues. PSMA expression does increase with higher grade tumors and metastatic disease. And because it's an enzyme, people have been able to make a number of ligands that bind to the enzyme and get internalized, and these together with antibodies have become incredibly useful for PET or even SPECT imaging. For the most part today, I will talk about both the gallium PSMA 11 ligand with which most of the world is very familiar and that we've been using at UCLA for the past 6 or 7 years and recently obtained FDA approval. I'll also talk about some of the data with the fluorine 18 molecule DFCPYL or PYL for short that also recently garnered FDA approval in UCLA. But these are just two of many additional ligands that have been generated that may be useful for imaging and or therapy as well. So I think the basic premise in terms of why PSMA is becoming so important is that it's become clear that imaging, or what we see, is dependent on the tracer that we use. And here are just two examples. On the right is the easiest to see. The bone scan, which we've used for decades, is on the left. And the same patient image with PSMA PET showing widespread metastatic disease. The patient is the same. The only thing different is the tracer that we used. And on the left, we can see, this is a case I'll show a little bit later, a lesion seen in the mediastinum of a patient who had had prostate cancer in the past. FDG PET did not show anything. Sodium fluoride PET lit up the bone, but that was also false positive. But he did have a PSMA positive lesion. So I'll first start the talk with PSMA for the detection and management of men with biochemical recurrence, because this has been studied first, and we have the most data in this disease setting. And I think for right now, PSMA performs the best as well for this disease setting. So first, just some data on detection. That is the ability of PSMA PET to detect a site, one or more sites of cancer in men who have biochemical recurrence. And what you will see is that the data is very similar regardless of the specific tracer. So this is our data from UCLA and UC San Francisco that led to FDA approval, showing gallium PSMA 11. And what one can see is, depending on the PSA threshold, the percentage of men who have detectable lesions increases, with about 38% of men having detectable lesions at a PSA less than 0.5 and 97% at a PSA greater than 5. And this holds true for PYL, the newer compound as well. These are the results of the recently presented and published Condor Study that also led to FDA approval. And one can see virtually identical detection rates, 36% for PSAs less than 0.5, all the way up to 97% for PSAs greater than 5. What is important, perhaps more than the detection rate, is the positive predictive value. That is, among men who had a positive lesion, what percentage of those men actually had disease at that location? And one can see the positive predictive values are quite high, 70 to 80% in the Condor study, actually somewhat higher in our own studies where we had pathologic confirmation or a composite measure of disease accuracy. What's also very interesting and important to recognize with PSMA PET in this setting is that we are seeing a real heterogeneity or variety of disease sites. Even if PSA is less than 0.5, we're seeing many patients who have pelvic nodes and actually a relatively small percentage who have prostate bed only recurrences. And of course, as the PSA gets to be higher, the distribution of these lesions increases, and as many as 50% have multiple regions, that is bone, pelvic nodes, and or prostate bed recurrences. And so this explains probably why traditional salvage radiation only works about 40 to 50% of the time, and that is because the disease is not in the prostate fossa or the prostate bed in a significant percentage of men who have biochemical recurrence. This is that case I just showed you, a man who had a prostatectomy back in 2004. He came to one of my colleagues in thoracic medicine because they found an 8 millimeter paramediastinal nodule. Because of his history of prostate cancer, we asked them to check a PSA, and then we obtained a PSMA PET, which showed that this was indeed prostate cancer. We resected this, and this stain for PSA demonstrating, confirming the presence of prostate cancer in this, what before used to be an unusual place, but we now see much, much more commonly. So what's the impact of PSMA imaging on management of patients with biochemical recurrence? And there are now many publications, and the bottom line is that PSMA imaging has a significant impact on management. As many as 50% of patients, management strategy changes based on this new information. And this can lead to the decreased use of salvage radiotherapy to the prostate fossa, increased use of salvage node dissection, stereotactic radiotherapy, and androgen deprivation therapy, and I'm going to focus on this over the next few minutes. So here are some of the possible management changes that one could envision in a patient who had a prostatectomy in the past and who has a biochemical recurrence using PSMA information. If PSMA PET is only in the prostate bed, then obviously the best option is radiation to the prostate bed, but the benefit may be the ability to avoid systemic treatment or radiation to the lymph nodes. If, on the other hand, the patient has disease in the pelvis or regional lymph nodes, then that patient may be treated with radiation to the pelvic nodes. One might avoid unnecessary radiation to the prostate bed, and more importantly, based on the localization of these lymph nodes, one might change the radiation fields, that is radiation planning, and I'll mention this in a clinical trial that we're doing. I'll focus a little bit on oligometastatic disease and how we might use PSMA PET to treat such patients and what is the evidence for doing so. So one possible use of PSMA imaging for planning salvage radiation is demonstrated here. In the green on the right is the standard template used for radiation in the salvage setting, but in the yellow were actually all of the different sites of disease that we have seen at UCLA and UC San Francisco on PSMA PET. And so the question is, can we use PSMA PET to guide the radiation template in this setting, with the hypothesis that at least 20% of patients could benefit by a wider field of radiation in this setting. And we've just completed a phase 3 randomized trial to ask whether including PSMA PET imaging can actually improve the outcomes of salvage radiotherapy, and we expect to have more data on this over the next year or two. The other common thing that we see now in biochemical recurrence is the patient with oligometastatic disease, generally defined as 1 to 5 metastatic sites. And this is just a typical patient of a man with Gleason 8 cancer. PSA was 0.27 4 years after surgery. He had a single positive lymph node in the left pelvis. I think this is an obturator node. And so then the question is, should we do salvage radiation? Do we need to do radiation to the prostate bed? Could we do only the node that's involved using metastasis-directed therapy? Should the patient maybe have a salvage lymphadenectomy? These are all the options that PSMA imaging opens, but the question about which is the most appropriate remains somewhat unknown. There are now a few studies looking at the question of metastasis-directed therapy using generally stereotactic radiation, suggesting that there might actually be benefit to using PSMA imaging to guide radiation only to the metastases in these patients. The STOMP study is probably the best known that has been done. This was 62 men who had a choline PET, not PSMA, so this is an older study, who had less than or equal to 3 metastases, and they were randomized to either get metastasis-directed therapy with stereotactic radiation or observation. The primary endpoint was actually unusual, which was the time to the need for androgen deprivation therapy. They also looked at time to progression. On the top, you can see that at least 50% of patients had a PSA decline. Most of these patients were in the arm that got metastasis-directed therapy, whereas the patients in the control arm generally progressed, as one would expect. On the bottom panel, one sees that indeed the addition of stereotactic or metastasis-directed therapy did increase the time until men needed androgen deprivation therapy, and this was significant. And it raises the question as to whether this is a valid endpoint that we should use. Certainly in terms of quality of life, delaying hormone therapy is probably beneficial from a patient point of view. Another study called the Oriole study was probably a little bit more interesting. This again randomized patients to stereotactic radiation in patients who had oligometastatic disease. But in this study, although they used choline PET to actually do the radiation and plan the radiation, they did obtain PSMA PET on all men so that they could look at the comparison of what happened in men who had all of their lesions that were detected by PSMA PET treated versus those who did not. And this is the data from that study, again suggesting a benefit for metastasis-directed therapy. I'll point you to the bottom two panels. In these two panels, they looked at progression-free survival and disease metastasis, distant metastasis-free survival in men based on whether their lesions detected on PSMA were all treated or not treated. So that means in cases where the choline and the PSMA essentially agreed, all lesions would have been treated. In patients where PSMA showed more than choline, not all lesions would be treated. And in patients in whom all lesions were treated, that is no untreated lesion, the progression-free survival was significantly better than in those who had any lesions untreated, suggesting that with improved imaging and more complete, therefore, therapy, one may see continued improvement. So now I'll shift for the second half of this talk to PSMA PET at the time of diagnosis. For all men and for men with high-risk prostate cancer, this is, of course, the most common thing that we urologists see. And I'll answer 3 questions. Number 1, how does PSMA imaging compare to conventional imaging? There are 2 studies at least that have addressed this question. This is one from my group that we published last year. And what this showed is that, as you would expect, PSMA imaging was better than conventional imaging. Positive nodes were detected in 30% of patients with PSMA PET, but only 11% with conventional imaging. And in 21% of cases, there was non-concordance between conventional imaging and PSMA imaging, with PSMA essentially winning in all cases. Importantly, in the case of bone lesions, PSMA PET helped exclude the presence of metastasis that was sometimes found on traditional bone scan, which, as we know, can overstage some patients. A similar result was obtained in a prospective study that was done in Australia called the ProPSA Study. And in this case, they again randomized everybody to receive PSMA or conventional imaging, and essentially looking at all of the parameters, specificity, area under the curve, sensitivity, and doing a number of sensitivity analyses. Basically, PSMA imaging was better for detection of local metastatic disease compared to conventional imaging, as shown here, suggesting that perhaps PSMA imaging will or can replace conventional imaging in prostate cancer staging. And I'm not talking about MRI here, which I'll mention in a second. This is conventional bone scan and CAT scan, primarily for detection of metastatic disease, but also locally advanced disease. So then there is the question is, should we be doing both PSMA imaging and MRI imaging? We have just submitted a publication on this, which hopefully will come out soon, but our data is consistent with these data just published in European Urology by a group in Australia. And what they showed is that PSMA PET does not add that much to MRI for detection of the local or primary disease. It improves, if you combine the two of them, it does improve the sensitivity from 83 or 90% in the case of MRI and PSMA to 97% by the combination. It definitely increases the negative predictive value from 72% for MRI to 91% for the combination. And this is consistent with the knowledge that MRI does not see all lesions, and that PSMA is clearly known to potentially detect lesions in men with negative MRI. However, there is a trade-off because PSMA PET is less specific than MRI, and the combination of the two leads to a loss of specificity, that is, perhaps more false positives. So, as in many things in medicine, there is a potential trade-off. I think for right now, I would not recommend combining these two imaging modalities. However, I think there may be discrete uses of PSMA PET in men who had MRI. For instance, a man with a negative MRI in whom you are very suspicious that they have cancer, PSMA PET, we have done a number of cases, has been very useful. Now, how about PSMA for staging of patients with high-risk disease? There are a number of studies now addressing this, at least 3. This is one published from Australia, which showed that the ability of PSMA to detect lymph node metastases that are found at the time of surgery is about 40%. So not as sensitive perhaps as for biochemical recurrence, but quite good compared to conventional imaging. But if one looks on a node per node basis, the sensitivity is lower. That is, there are quite a few nodes detected at the time of surgery that were not detected by PSMA PET. Usually it's because these are smaller lymph nodes. However, certainly there are even occasionally large lymph nodes that are missed by PSMA PET. So just be aware that you should not omit a pelvic lymph node dissection just because a patient has a PSMA negative scan. Indeed, in our own series, 25 to 30% of men with a negative PET scan but who have high-risk disease do have lymph node metastases detected at surgery. And this is the study from UCLA and UCSF, which is coming out to be published very soon, which showed very similar numbers with the sensitivity of between 30 and 47%, depending on the PSA level, in terms of PSMA detecting lymph nodes that were found at the time of surgery. But of course, importantly, if a lymph node looks positive on PSMA, that lesion is virtually always cancer with a very high specificity. This is similar data for PYL from the Osprey study, showing about 40% sensitivity is exactly as we have found with gallium PSMA, but the specificity is quite high. And so I think that PSMA PET has a clear role to play in these patients. In our own study, 30% of high-risk patients who underwent PSMA imaging had metastatic disease, and it is among the 70% who did not have metastatic disease by PSMA and then underwent surgery, in whom about 20 to 30% of patients still had positive lymph nodes. So then the question is the same as with biochemical recurrence. How should molecular imaging change the management of men with high-risk prostate cancer? Should we omit surgery if a patient has positive lymph nodes? Should we not do a pelvic node dissection if PSMA PET is negative? I just answered that as no. Should surgery be abandoned in favor of radiation and androgen deprivation in patients with positive lymph nodes? So many questions that we need to answer still that we do not have complete answers to. And I used to ask myself, are we better with PSMA PET, or was it better when we simply didn't know? Obviously, I think it's better to have more information, but we have many clinical trials left to complete and registries left to analyze to really answer what are the appropriate management changes that should be made based on PSMA PET. And here is an example of a patient who has high-risk prostate cancer. He has a lesion in the prostate, but he has a single lymph node, perirectal lymph node, or internal iliac lymph node that one can see. So should we still do surgery and try and remove that lymph node? Should we do surgery and radiate that lymph node? Should we switch to radiation and androgen deprivation therapy, etc., etc.? So there are still many remaining questions that need to be answered, as I have just outlined. So the final 3 slides are the exciting area of theranostics, that is combining the diagnostic with the therapy. There have now been a number of studies and reports published, including the most recent VISION trial, which is a randomized study of lutetium PSMA in patients with metastatic castration-resistant prostate cancer. Here's an example of the dramatic responses one can see using PSMA-targeted radiation. And here are the data from the VISION study showing an improved overall survival, statistically significant, and a delay in image-based progression in men receiving lutetium PSMA. I want to thank you for your attention and for the very kind invitation to participate, unfortunately at a distance with you. I want to acknowledge my many collaborators at UCLA, UC San Francisco, and of course to our patients who have participated in all of these clinical trials at UCLA over the past 7 years. Thank you very much.